Hello, everyone. Thank y'all for joining us tonight. We'll be getting started here in just a second as everybody's piling in. My name is Jacob Dent. For those who are on the class tonight, we're going to have a good session tonight talking about inclusive dentistry, and really just want to take this opportunity. I know we've all had long days at the office and want to make this of value to y'all as much as possible. And so as we get started, I'm going to try to keep our presentation tonight to around 45 minutes tops, and then open it up to some questions at the end. So let's get started. So with the class tonight, our biggest thing, talking about inclusive dentistry. Uh, I always like to kind of start off with a little bit about me. It's weird for me to not be in front of a group of people, or obviously to see faces. So, just this virtual, but this is me. Obviously, I live in Louisiana, born and raised, and I have I have been practicing for the last 20 years, which doesn't seem that long. But I've kind of taken this opportunity since 2016 to really focus my attention and my practices more on the treatment of adults and children with developmental and intellectual disabilities. So for tonight, our main objectives, as you can see, we're gonna talk about neurodiversity and what it means to be neurodivergent, and then how each team member at your office, including yourself, plays a role in creating a unique experience for neurodivergent patients. And then obviously, I'm going to go over some examples of sensory room designs, how to make your office more sensory friendly, and I'll show you some examples of what mine looked like. So really, to just begin, I always like to start with the why. Simon Sinek always says start with why. So my big why is this young gentleman here. This is my 19-year-old son, Ethan, who is on the spectrum. And so I graduated not being a special needs dentist. I had no intention of seeing patients with special needs because I had no training in it, like many of us coming out of dental and hygiene school. And I've been on a very in-depth residency with my son, learning both the dentist and the parent aspects of having a child who is neurodivergent. So, just a little background on neurodivergent. Judy Singer is the sociologist that came up with the term neurodiversity back in '98, and her viewpoint was brains are kind of like fingerprints. There are no two that are the same. And it doesn't mean that just because someone is different, they're less. And so, to define what neurodiversity is, it's the concept where neurological differences are seen as natural variations of the brain, and those differences are recognized and respected and celebrated. So we look at a lot of times we look at patients that come in that are disabled in some way, both physically and neurologically, and a lot of times we look at ourselves as neurotypical, and what that tends to cause us to do is view them as less, or almost have a sympathy for them in a way that really is unnecessary. And so, one of the things I hope that y'all take away from tonight is when you treat a patient that has autism or Down syndrome or cerebral palsy, or just the basics of just dental anxiety, that's not necessarily something that we should look at as odd, but it is different, and it's different from us and what we know and have been trained all these years on how to not only treat our patients from a dental aspect, but also just a personal aspect in creating those relationships. So, the term neurodivergent is anyone whose brain differs from what we consider to be normal or neurotypical. So, as you see this diagram, we can see probably the majority of all of us would fit in that upper left-hand neurotypical. But, as we look around these, the anxiety, depression, how many of our patients click that button? Um, they're taking some form of medicine that helps with their anxiety or depression. Even ADHD is a more common uh, issue that patients present with these days, and we don't really have to change our delivery system and how we change our environment in our office or how we go about our regular routines. And so, what I want to show y'all is what a typical appointment looks like versus what a inclusive aspect of dentistry can look like. And we're going to go through some of the ways that I've done that and transition my practices. So, uh, in regards to a normal dental visit, what I've created here, I have this in my office. It's what's called a social story, and so for patients that are usually on the spectrum or someone that comes into your practice that needs a more of a visual aid on what's going to be happening, I've created this. So what does a typical visit look like? Obviously, we meet the dentist, we wait our turn. Um, Play with toys. This is when Ethan was much smaller. And, you know, we go through the basics of a regular exam. We take our x-rays, we sit in the chair. In my office, we give our patients glasses to put on. I put my gloves on and get ready to do my exam. And then we brush our teeth. Great visit, and we get to go. Now, that seems like a very simplistic version of our normal dental visits. But unfortunately, for neurodivergent patients, a lot of those aspects are terrifying. And I think one of the things that we don't realize is that when we go to the dentist and we sit in our offices as a patient, we see things a little differently. Our perspective changes, and a lot of those things that we see that affect how we perceive a dentist visit. It really comes down to our sensory inputs. And for those neurodivergent patients that may have a different hyper or hyposensitivity to certain aspects of a dental visit, those can be outright terrifying. So one thing is most people really look at a dental visit in the five senses. That we all think we have five senses. We actually have eight, and those other three that most don't know about or really talk about a lot are proprioception, interoceptive, and the third one has more to do with your head position. So for when we talk about things like leaning a patient back in a chair, just the simple thing of sitting in a chair and leaning back, that can be a cause of distress for some patients. So as we go through what neurodiverse or a more inclusive appointment looks like in my practice, it could be like this patient here. This is a 44-year-old female who is on the spectrum. And prior to coming to my office, she had only been seen under sedation. And so she was terrified just to walk into my door. If you've ever seen those patients that look like a cat being thrown in the water before they even walk into your door, and they're just freaking out, having meltdowns or just almost shaking. That was this young lady. And the thought of walking to a room, sitting in a chair, it wasn't going to happen. So what we had to do in this particular case is we had to meet her where she was. And for her, she was comfortable in our waiting room. And we spent the time and we took the opportunity to let her acclimate to me and the environment. And that was really the biggest pearl that I had to learn early on was it wasn't the patient that had to adapt to me. I had to adapt to the patient. So another opportunity was this is a gentleman here that I've been treating for several years. And he and his family actually drive 3 hours one way, all the way from Houston, Texas, because no one else is willing to see him without sedating him. And I don't sedate any of my patients. I don't believe in it when it comes to the basics of just oral hygiene and brushing teeth. I focus more on desensitization, and we'll go through how I do that in my practice. But for this particular gentleman, he's verbal. He is very much aware. The first time I saw him, his elderly mother brought him into my office. It was not willingly, and this gentleman was the first patient that ever caught me with the left hook. Um, and it made me kind of wake up and go, hey man, I am forcing a situation that doesn't need to happen. Now, I've been seeing this patient for 3 years, and this picture right here was last year, and this is the first time that I haven't had to lean through a car window to do an exam and brush his teeth. And so we have graduated to a chair outside the car. But many of us are thinking to ourselves right now, there ain't a chance that I would go do a parking lot dental cleaning. If for the doctors on the call, absolutely, that's probably so far outside of the norm. For hygienists, you're thinking, yeah, that's probably not going to be a very quality cleaning. If I have to hand scale everything and just do basically basically what I would consider mash unit type dentistry. But this is what it takes to change the perception of our neurodivergent patients, to allow them to get to the point where they're desensitized to the person and the process, so they will get to the level where they can go sit in a chair, sit in your operatory, have any of your team members treat them, and do it without sedation. So, so let's talk about real quick the roles of that everyone plays and what a neurodivergent appointment looks like in my office. So we'll start with the front desk. That's usually the best and first line of defense when it comes to making an appointment. And so right now I'm looking at it with what we call a getting to know questionnaire. So we all have health histories. We all have things that we normally give our patients. Yes, tell me about your dental history. Tell me about your medical history. But what we don't ask, that's very important for our neurodivergent patients, is tell me about what your routines look like at home. And if there is a caregiver or a parent involved, I want to know from them, what does that routine look like, and how is their involvement in that daily routine um, working out? Is it even an efficient brushing at home, or is it even happening at all? Because I will tell you this right now, there is nothing that you or I are going to do twice a year that is going to make a bit of difference if the home care is not up to snuff. And so the getting to know you questionnaire is actually something that I developed as a parent of a child with intellectual disabilities, that I wanted a caregiver to know, a healthcare provider to know about my son. And a lot of those things included, what is his triggers? What is his abilities currently? So for example, Ethan at 19, he's verbal, he can talk to you, but he is more hypersensitive to loud noises. Things like a vacuum cleaner or a blow dryer at home can be very unsettling for him. So things like our high-speed suctions really sounds like a vacuum cleaner. And that can that can trigger a meltdown in the practice before we even get started. But I also wanted to ask questions that were a lot more practical. So for hygiene, I want to know what type of toothpaste flavor they're using at home, because if they hate mint and love fruit or bubble gum, and the first thing you pick up without asking is mint, but maybe you ask and they're nonverbal and they can't communicate that, that's going to freak them out. I'll even give you a better example. My son grew up hating the tags in his clothes. We had to cut every one of them out. And so, what is the first thing that happens when you sit a patient in a chair? You put a big old tag right across their chest. And for patients that have that sensitivity, you will cause a meltdown immediately. So these are things that are very important for all of us to know before we even get a patient into our office. This helps me prep myself and my staff on what we're going to be dealing with and how to adapt our delivery system to each individual patient. The second thing that we do is we talk about scheduling. Now, one of the hardest things that we do as dentists and hygienists is we normally have practices that are blowing and going. We have 2 or 3 patients in the chair at a time. We have probably an office full of people sitting in the waiting room, and that in itself can be very overstimulating for patients that are very anxious, ADHD, or fall under the spectrum of intellectual and developmental disability. So scheduling the appropriate times for our patients is just as crucial as how we deliver our services. And so a lot of the things in my office that we do different is I have on Monday mornings and Tuesday mornings, we have sensory friendly hours. So what that means is I only schedule one person an hour that falls under our special needs categories, and we turn off all the fluorescent lights, we turn off all the overhead music, and we create an environment that's inviting for the families, caregivers, anybody that's coming in during those hours. Now, do we get to see a ton of people? Absolutely not. But what we do is we're creating a value for that time. So my sensory hour times are actually booked out 6 months. I don't have any new time available for that, and the waiting list is long. Now, when you look at talking about the actual times available, I'll give you an example that really kind of hits home for most is everybody wants what we call our convenient hours, our prime hours. The first appointment in the morning, first appointment after lunch, maybe the evening appointments right after work, etc. But for a neurodivergent patient like my son, for example, he takes his medicine with breakfast. So I don't want to schedule any doctor appointment at 11, 12 o'clock in the middle of the day when his medicine has wore off and he may not be as focused as he could be. Also, for your kids that are in school, I don't want to schedule a child with a intellectual developmental disability or someone with ADHD at 3 o'clock when they've been drilled at school for 8 hours and expect them to come in and actually perform a quality dental visit and exam. They're burnt. They don't want to be there, and it usually turns into a bad result. In regards to the SN1, SN2, SN3 coding that I do in my practice, what that is it's a numbering system for me and my staff to understand the level of the patient. So SN1s are the numbers that we give all of our new patients. What that means is that I personally am in the room for the full time. I give everybody an hour, and I'm in there. And whatever we get done, we get done. And I will tell you, probably out of that hour, I spend maybe 10 minutes doing dentistry, and I spend the rest of the time coaching and talking to the parents or caregivers to make sure that they're comfortable. I always say when someone comes in with a child or an adult that they're the caregiver for, I'm going to treat that person's anxiety well before I treat the patient's. And so I create that initial connection, that initial relationship, because that is the most crucial time to do it in that first visit. With the SN2 patient, that is a patient that comes in that does not have a, let's just say, a very intense behavioral issue. So they've been able to at least do some aspect of an initial exam and visit, but they have not mastered everything. And they have not graduated to the SN3 role, which is that person can do exam, x-rays, cleaning, sit in a chair, and they can do it with any of my staff members. So in my office, I don't let my hygienist ever see a special needs patient or one of my neurodivergent patients until they have graduated my desensitization program and are now in SN3. And that's the goal for me, everyone. I don't want anyone to ever come into my office and go, man, I don't know what we're going to do when Dr. Dent decides to retire, because there will be a day, God willing, that I do retire. And my goal is for the child or the adult to have gotten to a point in their life where they could go to any dentist, any hygienist at any stage of their life and at least maintain their oral health without having to be sedated to do it. So that is the overall goal. And so the front desk role is very important, because this is the information kind of gathering and obviously scheduling it appropriately. The getting to know you form, this is just what the first page of it looks like. And after this class is over, I will actually share with you my website, my email address. And if anybody would like a copy of it, just email me and I'll be more than happy to send you that. And like I said, you're more than welcome to incorporate that into your practice as well. So again, it just really goes over those sensory issues, any triggers. Expectations is a huge, huge thing to identify, especially with the parents. We all enjoy helicopter parents that come into our practice. And they're more nervous and anxious about how the child is going to react and respond, because they probably have had a very negative experience. And so we're creating a very inclusive environment for the caregiver and the parent as well. So one big thing about this, just so y'all know, is anytime someone says, hey, I want to see Dr. Dent for, my neurodivergent child or adult that we're caring for, I send them this ahead of time. They have to fill this out and it be back within 24 hours, or I will not see them, because I'm not going to I can't create an environment that is very unique for each patient without having this knowledge. And I don't do it on the fly. We talked about the scheduling. And again, that just breaks down for you what we just said about having mastered everything as an SN3, but what the SN1s, and I didn't include it, but SN1s are our new patients, but also patients that require any type of medical protective stabilization, or those are the patients that may come in and someone has given them a Valium or something. I don't IV sedate anybody, but there are some patients that come in that we do give a Valium or something, or their primary care has given it to them just to get them basically out the house and in the car. So as far as the clinical team in the back and what our role is in this, and how we can include everyone as part of this team member inclusive dentistry, is we really want to focus on establishing that relationship with the patient and caregiver. And like I said, docs, I know our big thing is, hey, they go, a regular neurotypical patient will come into your practice. They go to x-rays, hygiene does their perio exam. If it's all good, they get them cleaned up. Everything's great. Doc, can you come in at the end of the exam? We do a thorough exam, and we tell them, thanks for coming. And that's the norm. And there's nothing wrong with the norm, but the norm doesn't necessarily apply to anyone but a neurotypical patient. And unfortunately, anybody that has dental anxiety no longer falls under neurotypical because it does require a lot of um, effort on their part to even get into your door. So we kind of need to treat all of our anxiety patients in this same way. So like I said, all new patients for me get an hour appointment. And uh, we really focus on what the patient can do and build from there. So if you think about it, it's a lot like someone coming into a classroom, and if someone didn't know their ABCs, I'm not going to expect they're going to start writing sentences. So we meet our patients where they are, and we do not judge any of the patients for being ahead or behind. And a lot of that really is dependent upon their intellectual ability, but also their physical ability. Because a lot of patients, for example, um, you know, my patients that have cerebral palsy, I can't expect that they can brush their own teeth efficiently. But I also have a neurotypical child that, does a zip zap type of brushing, and that's not efficient either. And so we really want to treat everybody where they are. And when we talk about how does this look as far as office space, so your waiting room, sensory rooms, etc. So I'm going to show you all some pictures of what mine looks like. This is my waiting room. So I've created. I have I would call it a neurotypical waiting room, and then this is my neurodivergent sensory room. And one of the things in here, as you notice, we don't have the chairs side by side. It's what we call flexible seating. It's those benches in the corner that are by the iPads. In this picture, you can't see, but right to the left of that alphabet foam puzzle piece there, there is a little futon sofa. And then also in here, I have one of those 6 foot large bean bags. So when someone comes in, I want them to be able to feel comfortable in the environment, because a good rule for me has always been new person, new environment's a bad result. So we wanted to create a sensory friendly environment that someone would fit anywhere in this room. As in regards to, this is my open bay, my sensory operatory. And so uh, I created this to have 3 different types of delivery systems. So all the way to the wall is a typical ortho bench. And I did that for our patients that have that sensory hypersensitivity to being laid back in a chair. They can lay down in their own bed, so they can crawl in and lay themselves down, but they may be very sensitive to you shifting a traditional dental chair. In the middle there is just a mobile cart, and that's for our patients that can't transfer out of a wheelchair. So we created that opportunity for them to stay in the chair. Now, a lot of you are looking going, there's a blow up canoe in your office. Yes, there is. There's also a trampoline because a lot of kids have that proprioception hyposensitivity, which is like Ethan. He's the kid that will get on a swing set and he will continue to swing until he touches the sun. And he needs that sensory input. For some that run into the office and they're bouncing all over the walls, and the ADHD kids that can't focus, then I'll let them go bounce on that trampoline till it's time for them to come, so they get the sensory input they need before we ask them to calmly try to sit down. But the canoe is actually a sensory canoe. The kids will sit in there and it kind of squeezes them, gives them a little hug. It also helps them with balance in between. But I'll have kids that will sit in that and I'll just drag them through the office and I'll clean them right there on the floor with that little mobile cart. Another example of a private room, just a single delivery, is again, one of the things that you have to create as far as desensitization goes is it has to be reproducible. And I don't know many people that can go to someone's house and replicate a dental chair. So what we did is we created a room with the little mobile cart, but that's just a little $5 bean bag from Walmart. And so what I wanted to do is whether it was at home or maybe at a therapy or a school, they could get the same bean bag and they could practice brushing teeth at home and school in the bean bag. And so when they came to the office, it was very familiar. And then as we introduced our dental items like a suction or air water syringe, or even a Profi toothbrush, a little Profi cup toothbrush, that in itself is a lot easier to adapt to if they're comfortable with the environment. So like I said, you can do anything in your office very simply and very inexpensively. And I'll tell you, if most of us all have our ops equipped. So if you get a beanbag like that and you already have a chair in your room, then put the beanbag in the chair and let the patient sit in the beanbag. And then as you desensitize them to the beanbag, then you could eventually remove the beanbag and they will sit in the chair. And that's how you prevent those initial meltdowns or fights to even get them to sit in a dental operatory or chair. So when we talk about desensitization, that is simply just exactly what it sounds. We are taking the oversensitized areas of our brain, and we are trying to limit the triggers that come with it. So here's just an example of how I do it. So same sensory room that I showed you the picture of. The child with the rainbow dress in the back, that is the neurotypical sister or sibling of the young man that's sitting on the floor with me, who is nonverbal and on the spectrum. Now, we have gotten mastered in this. I can do a very good visual exam, and he will let me do a toothbrush Profi and doesn't fight me as long as I'm sitting on the floor. But if he tries to get into a chair, he turns into, a Wolverine and goes crazy. So the other person here that you see with the plaid shirt, the other bald head, that is actually his therapist who is there recording him and taking pictures so they can create a social story like I showed you in the beginning of this presentation. So he can have his own personalized social story on his iPad, and he can learn the steps of what's going to happen. So it helps calm him and helps desensitize him to what we're going to be doing. This is my own invention. I actually created a take-home dental sensory kit for patients, and with this kit comes a manual toothbrush that's to the left, and it's a three-sided head toothbrush. But you'll notice I put a dental bite block built into the back of that handle, and the reason for that is because there's a lot of our older patients, our Alzheimer's dementia patients that come in, and caregivers just can't get them to open their mouth or keep their mouth open without wanting to chew or break a toothbrush or bite them, obviously. So I created this toothbrush to allow the caregiver more access. And inside of that kit, this is everything that's in the kit. So again, it goes just from a sensory input. So obviously gloves and masks are something that's, especially masks, are a little more common now thanks to COVID. But a bib, obviously, like I said before, with the sensory issue to tags and Ethan's shirt, Profi paste, it may be the same flavor bubble gum that you have at home, but because of the grit, there is a texture to it that can also be a sensory portion for patients. A Profi cup, they may be great with a regular toothbrush, but if they've never seen a Profi cup before and you pick that up, put their same toothpaste on it, they will freak out. A small suction, obviously, to help practice with closing their mouth around it as a straw. A dental mirror for a good exam. The foam trays, everybody asks, most people now do not do foam fluoride. I don't. I use varnish, but I put that in my kit because we still at some point want x-rays for all of our patients. And so they can take this and cut it into two separate pieces, put that in a mouth, and practice holding that, for 5-10 seconds to help replicate a typical dental bite wing or x-ray that we need to take. A flosser with a handle, and then obviously the triple bristle three-sided head that fits on my handle. And this is just kind of what that looks like when we brush around teeth. So the three-sided brush head, like I said, I've partnered with a group from Triple Bristle, and they actually invented this for perio patients, not for special needs, but it works. And here is a good rule for patients that are intellectually and developmentally disabled. I'm sorry. Or maybe your elderly patients who have rheumatoid arthritis and they can't really hold a regular toothbrush anymore. So the rule is this: if a patient cannot tie their own shoe, then they do not have the dexterity to take a standard dental toothbrush and roll it in the direction that's necessary for them to get those gum line areas. Like Ethan is great at hacksaw brushing, but he will not roll it to get his gum lines. And that will be a very big concern when it comes to perio health long term. So something like a three-sided toothbrush, like we have here, works really well. And overall, with the being an inclusive dentist and dental practice, we also have to think about how are we going to deliver dentistry. So these are just a few examples of tools that I have in my office. The left is a rainbow board. Obviously, it flexes in a dental chair, but it is just two pieces of Velcro, and I do not ever strap anybody's hands down or anything. But for patients that require and like a firmer pressure, this works really well for that sensory input. And obviously, for some patients that what I call the dental ninja, they're doing everything to keep you away from their mouth. Another good pearl here is you can only manage one body part at a time. And so if you're trying to manage the head, you can't have arms and legs coming at you. So this is another good way to help with that. For hygiene, the bite blocks with a little external handle and the hole through it so you can put your small suction. So I always say this is how we all grow that third arm that we've been looking for all these years, and how to manage, obviously, helping stabilize a patient and still provide quality care. Arm and leg stabilizers. This is from Specialized Care Company. I love these because this is what can take your patient and that maybe you don't want to use any type of wrap, but this makes it to where they can't bend their arms or their legs. So it kind of turns them into a tin man, and they can't reach their mouth with those on. And they're strictly just Velcro, kind of like a little arm brace, but very well received, very easy to go on, and can still move, but they can't get to their mouth. So what are some alternative options that I teach the parent or caregiver? The first thing is with this lady here, obviously she's handicapped, she's nonverbal, mentally disabled, and this was one of those after the parent died, the sibling took over her care, and nobody wanted to treat her. Massive perio, multiple infected teeth, and they were like, there's a 2-year waiting list to get into a hospital. And even as someone who focuses their practice on special needs, I don't have hospital privileges. So I have to come up with alternative ways. So very simply, for all the parents out there, all I did was take a $5 little fleece blanket from Walmart, and I swaddled her in her own chair. And I've pulled teeth on her, done perio cleanings with her, and just it made life so much simpler. To the right, this is how I teach parents to clean teeth at home when you have what I call the dental ninja. So we just do floor stabilization. You lay on the floor, put them in between your legs, and you put their arms underneath your thighs so they can still move. They could still, I have a lot of kids that like to hold their iPads while we do it, but they cannot reach their mouths with their hands. So this is another way that's easily done if you don't have those arm stabilizers. And I'll demonstrate this in my office, either on the floor or on that big beanbag with the parents, and then have them demonstrate it back as well. I don't know if anybody has never used silver diming before, but one of the big challenges comes to, okay, doc, great, you can brush their teeth, you can, you can get an exam, but what happens when you actually have a cavity or something that you have to fill? How are you going to do that without sedating them? And so this is how I do it. Silver diming fluoride has been kind of a game changer for me in my practice. And so, we'll go in there, we'll paint that SDF onto a tooth. I usually wait 2 weeks. I have them come back, and then we'll clean that cavo surface out with usually a slow speed or even just a spoon excavator, and just eliminate high speeds in general. And then I fill the top of it with a glass ionomer. Usually Fuji Equia is my go-to. And occlusion is usually a thumb occlusion or Q-tip, smooth it out and have the patient close down and bite. And this patient right here, this is an example. This was a 13-year-old that came to me. He was on the spectrum, the previous dentist said he needed a root canal. Decay was sitting on the pulp horn, not exposed, but X-ray was very close. We treated it with SDF, put this Fuji on top of it, and 5-year post-op, still has never had to have a cavity refilled in that tooth or had to have the root canal. So it's really been something that has made a huge difference as far as being more sensory friendly, but still providing care to those that may not be at a level that can do the dentistry without being sedated, but it buys you time to help desensitize them. And when the time comes where they're able to do it, you can always go back and do a more traditional dentistry if necessary. So pearls of wisdom, just kind of in closing as we're wrapping up tonight. Remember, new person in new environment is going to give you a bad result. I always recommend let the caregiver or parent be the dentist first. So here's the thing. If you bring someone back, even if it's just a neurotypical child, and that child loses their mind, that parent is going to look at you as a bad dentist or a bad hygienist. And I always say, as a parent, we lie. We think our children are wonderful little angels, and we will tell lies about them, even if they're little demons at the house. And so I will tell the parent, okay, great. Susie is just an angel. Can you show me exactly what it looks like at home? And this is usually the parent that says, look, I don't want any form of stabilization or sedation or, anything. And this is the parent that looks like they're having a WrestleMania match. They got them in a headlock. They're rolling around the ground. And I'm thinking to myself, okay, I'm glad I let you do that, because the parent will look at you and go, okay, maybe it's not going as well. And that helps me build a better relationship with the parent, because I'll tell them, well, let me show you a few tricks that may make your life easier. And that connection right there is priceless, because then they're on your team, and you've got a much better chance of getting a buy-in from the parent on your desensitization versus that helicopter parent that will be the thorn in your side as long as they're patients in your practice. And then the last thing is, always remember the part where not every visit will go well. You may have a patient that one day comes in and does everything you ask and is perfect. And the next day they could come in and they just lose it. And you're like, nothing's changed. And it's okay, because a lot of our neurodivergent patients are having other issues that are causing them distress that have nothing to do with us. And you know what? It just may be a bad day. So as much as we as dental professionals want to be perfect, it's okay not to be perfect. And not every cleaning, this is for all of my hygienists here, not every cleaning is going to be perfect. You're not going to get every stitch of tartar off. You're not going to get a, textbook cleaning. Doc, sometimes you're going to look at it and go, okay, I don't know if I'm even doing a good job because I can't get x-rays. I may not get x-rays on a patient for a year or two. And I'm going to go, God, I'm probably missing stuff. And you probably are. But here's one thing to remember. If you're not willing to do it, who else is? Because I guarantee you, everybody else is just going to pass the buck to someone and say, hey, look, I'm sorry, we're not equipped for a special needs patient or a neurodivergent patient. So take the initiative, and do your best. That's all anybody can ask of us. And as a parent of a special needs child, I'm looking for people that are just willing to try, because I know how tough it is. So lastly, thank you all for the time. We're going to do a quick Q&A. Obviously, if you have any questions, I'm going to go through these, and I'll answer as many as I can. But this is my website, Special Needs Warrior Doc, and my email, drdent@specialneedswarriordoc.com. You can also follow me on social media. But if y'all have any questions or anybody wants to look at that getting to know you form or anything, I'll be happy to send that to you. Just send me your email. So let's just say, Melissa asked, I was wondering how you tackle getting radiographs on these patients when they require parking lot or waiting room checks. Not always a very doable thing. I will tell you, in my office, we do have a Nomad. So that definitely helps with some of the floor or waiting room patients. If we can make it a little more mobile, that's always helpful. But you're not always going to get it. I have a CBCT in my office, and sometimes we practice on just getting that initial Pano or CBCT. And I just tell the parents, look, we're going to do our best to look at it. Now, don't get me wrong. If there is an emergency, if someone fell in my parking lot and busted a tooth and I needed to do it, I will use, just like a hospital, I'll stabilize them, I'll get it done, but it doesn't necessarily help desensitize them to it. It just proves that I'm bigger than they are. So I hope that helped. Let's see, Camille, I have a patient that's not a fan of flavored toothpaste. Yes, I've had that before. There's something you recommend that's unflavored that contains fluoride. I'm sure y'all all have the patient that say, fluoride is poison. We don't want fluoride. What else do you have? And so, I always say with that, anything that has arginine or xylitol is also a very good alternative for parents. And please understand, when people don't want fluoride, it's because, especially like on the spectrum, I was told when we got our diagnosis that it was because of neurotoxins, and we needed to basically detox Ethan to get him to just basically cure him. Well, obviously there was a lot of ignorance into that, and so I really challenged myself to go, I'm not going to judge my patients, but I need to give them an alternative that is as at least helpful. It's better than, making your own all natural toothpaste. So what I personally use, I use Floramax from Elevate Oral Care, who also happens to make the Advantage Arrest, the SDF. It comes in bubblegum, candy apple, and mint. And it comes in a pump, so you can actually squirt it out, and it's measured out so they can't overdo it, because we know a lot of our patients don't spit and they just swallow everything, and that's okay. A lot of that, as far as unflavored, there's a lot of things on the market that don't necessarily have very strong flavors, but it really is going to come down to I've not found anything that has fluoride with unflavored. So if I ever come across it, I will definitely, make that as part of my presentations. But another thing for patients that are more cavity prone, EPIC, EPIC, is a brand name of like gums and mints and candies, especially for kids, and they are xylitol. So that's also a big help. Let's see, Miss Tanya, are parents always allowed to go back into the operatory with their child? Um, Absolutely. I look at it like this, like I said in the beginning, if a parent is in the waiting room and their child loses their mind, then I'm a bad dentist. If the parent is with me, it's kind of like having Michael Jordan on your team. They know their child or the person they're caring for better than anybody else. And I am dumb if I'm going to take that away from my team. But I will be very clear and I'll say if a parent is also causing anxiety and stress to the patient, then I will ask the parent to leave. So I give them the opportunity to come, but I will tell you one of the biggest things that I know when I gain that trust with the parent is I have a lot of parents that say, no, they can go back by themselves. I will wait out here because they trust me and my team to do it. And they know that the child or the adult needs that independence because they're not always going to be here. And that is my biggest concern as a parent is there will be a day that I'm not here. And, I need someone to be able to care for Ethan and Ethan to be able to maintain himself. And you also you have a severely disabled 6-year-old child myself, and I thoroughly enjoyed the presentation. Thank you very much, Tanya. I hope this was of value to everybody. And like I said, if you didn't get a chance to ask a question, or if anybody has further questions, please, like I said, email me. You can send me a Facebook message. I'll respond to those as well. And like I said, I look forward to any questions that come our way. I hope everyone has a good evening. It's shutdown time for all of us. So I hope everybody goes and has a nice glass of wine or whatever you prefer and enjoy the rest of your week. But thank you all again, and y'all have a good evening.